Уважаемые коллеги, продолжаем нашу конференцию. Видно, обед здорово повлиял на наши мозги. Пожалуйста, проходите в зал. Сейчас будет очень интересная сессия. Евгений Дмитриевич, пожалуйста, вам слово.
У нас такая комбинированный вариант. Лекция, которую подготовил профессор Zhang Shutian, а читать лекцию будет наша коллега, профессор Rui Cheng. Мы ее... Rui, please. It's your turn now.
Давайте поаплодируем, поприветствуем наших гостей.
Да. Китайско-Российский эндоскопический форум. Да. Доклады в рамках Китайско-Российского эндоскопического форума. Договорились, что они будут идти на английском языке, который не является родным ни для нас, ни для специалистов Китайской Народной Республики. Тем более нам будет легко найти общий язык. I just explained that English is not native language, both not for you, not for us. So we will find a way for communication. Please, your turn.
Okay, thank you.
You're welcome.
Thank you so much. It's my great honor to have this opportunity to come this very beautiful city, St. Petersburg in Russia. And I extend my sincere gratitude to Professor Fedorov, Korolov, and Starkov, and all for this invitation. On behalf of Professor Zhang Shutian, Director of our hospital, I present today's lecture entitled Endoscopic Diagnosis and Treatment of Early Gastrointestinal Cancer, a standardized multidisciplinary food chain management. And according to the 2020 WHO data, the incidence of colorectal cancer, gastric cancer, and esophageal cancer in China ranks second, third, and fifth among malignant tumors, respectively. These three tumor types account for 28.73% to 53% of global incidence and 30% to 55% of global mortality, representing a significant oncological burden in China. And the lung cancer remains the malignancy with the highest incidence and mortality rates in China. The collective burden of gastrointestinal cancer, including esophageal, gastric, and colorectal cancers, surpasses that of the lung cancer. The gastrointestinal cancer, including the three-type cancer, surpasses lung cancer in incidence rate, now ranking first among all malignancies in China. And annual healthcare expenditures for gastrointestinal cancer exceeds 60 billion RMB, ranking first among all the cancers in China. So the standardized endoscopic screening and treatment are the keys for reducing the incidence and the mortality of gastrointestinal cancer. In the gastrointestinal malignancy universal progress through precancerous condition and early cancer condition. And the esophageal cancer is from the baroesophagus and the reflux esophagitis preceded dysplastic epithelial changes. And the gastric cancer, the precancerous condition is the chronic atrophic gastritis and intestinal metaplasia serve as precursors. And the colorectal cancer, adenomatous polyps demand timely intervention to prevent progression to advanced carcinoma. So the priority research directions in gastrointestinal oncology should emphasize the molecular characterization of early-stage malignancies and pre-malignancy conditions, coupled with the development of standardized diagnostic therapeutic therapeutic the algorithm to optimize the detection and intervention outcomes. And this is the standardized multidisciplinary food chain management. And Professor Zhang and Professor Li have pioneered this framework, which include 9 key components. The first one is the preventive strategies. The doctor's targeted education and awareness campaigns the people's lifestyle changes. And then is the early screening, and then is the early diagnosis and early treatment. And the very important procedure is the specimen pre-processing in endoscopy center. Our endoscopic center nurse will perform the pre-processing of the tissue specimens following the endoscopic resection, including specimen fixation, labeling, and standardized documentation to ensure the pathological diagnostic accuracy. Subsequently, upon arrival at the pathology department, the post-endoscopic resection specimens undergo standardized processing by certified pathology technicians, including the cross-examination, tissue bending, and the microtome sectioning, and the HE staining under the strict quality control protocols. And next is the pathology report. The pathologist should provide accurate readings and standardized report at the accurate stage before the Chinese standard, such as the high-grade dysplasia is according to the WHO classification, and early cancer is according to the Japan classification. And the next step is we will focus on the perioperative management. It's the standard and meticulous, the fasting and fluid refreshment and anti-infection, or the gastric tube and the system observation and the laboratory test. And the last step is the post-operative follow-up, the multidisciplinary standardized follow-up by gastroenterology, surgery, and pathology department. This is the food chain concept. The food chain concept clinical care framework emphasizes the integration of the multidisciplinary personnel across the diagnostic and the therapeutic continuum. Emphasize the food chain concept. The personnel include the doctor, nurse, and the pathology technicians, and the pathologist. And the food chain clinical care framework, the standard diagnosis and treatment of the early gastrointestinal cancer covers multiple departments, including the gastroenterology, general surgery, pathology, imaging, anesthesia, and other disciplines. It requires close collaboration between the endoscopist and the pathologist, endoscopist and the nurse, and the pathologist and the pathologist technicians, and constitute the core of the whole chain concept. In the process of the endoscopic screening, intensive examination, and resection and follow-up, in addition to endoscopists, education personnel, the nurses, and the anesthesiologists and the surgical colleagues need to play an important role in this food chain. And the links of the food chain are interlinked. And the shortfall of any link will affect the overall efficacy. Through the targeted education and awareness campaigns, physicians empower the patients to recognize the risk of GI cancer and shift their mindset from the wait for symptoms to proactive prevention. Because the characteristic symptom of the early GI cancer is asymptomatic. and emphasize the systematic health checkups, including gastroscopy and colonoscopy to achieve early screening. We conduct comprehensive public awareness initiatives through devised platforms and approaches, including the hospital-based education, public serve activities, and media engagement. The standard endoscopy screening is the foundation for the diagnosis and the treatment of early digestive tract cancer, while light endoscopy is the foundation of endoscopy screening. According to the domestic and international research statistics, the missed diagnosis rate in upper GI endoscopy screening are the hypopharyngeal cancer is about 35.54%, and the esophageal squamous cell carcinoma is 4.2%, and the esophageal adenocarcinoma is 6.1%, and the gastric cancer is about the 5.7%. And the very important is how to do a very standardized endoscopy is according to the standardized training from the theory and the practice, and the endoscopic pathological correlation and the nursing team coordination. We have the innovation in endoscopy training mode. We call this the 4-level endoscopy training system in our digestive endoscopy training center. The first step is we use the computer stimulator, and we have the first stimulated endoscope in Asia. And in next step is the model teaching. We use the in vivo model simulation, and then is the lab animal simulation, and the last step is the clinical practice. We use the hands-on teaching to the clinical practice. And this is our learning cycle in the 4-level the system. We will spend 1 to 2 weeks to finish the theoretical learning, and then is the 3 to 4 weeks of the observation and the simulator, and then is the animal model simulation, and then is the hands-on learning. Last, we will give a test for the students. All the time is we'll spend 6 months. This is the GI matter, the simulator. It will improve the learning curve and reduce patient pain and reduce the complication of the patient. We can do the gastroscopy and colonoscopy and the EUS on this simulator. And this is the animal model simulation in visual. Reduce the difference in experience from the simulators to real operation. We will use the virtual animal model for endoscopy training, the EMR and the ESD. Reduce the experience differences from the simulator to real-world operations. We will use the in visual animal models to the lab animal model to practice the EMR and the ESD and some other, such as the POM operations. Because the lab animal model for the EMR or ESD procedure provides a highly realistic surgical simulation, and particularly for managing intraoperative complications such as the bleeding and the perforation and the mirroring the real clinical sceneries. And the next step is the hands-on learning. The teacher will stand behind the students, intervening and providing guidance in a timely manner. Avoid badness, improve targeting, and enhance the motivation. Also, for the early diagnosis and the treatment of GI cancer, we adhere to the latest clinical guidelines and the expert consensus recommendations, especially for early up GI cancer in high-risk population. We strongly advocate the use of the standard magnification endoscopy as the preferred screening and diagnostic modality. And this is the expert consensus on the routine magnifying endoscopy in combination with pathology for early digestive cancer. And in this consensus, the framework for the routine magnifying endoscopy, it divided into two parts. One is the endoscopy section, and the other one is the pathology section. And the first consensus opinion in units where conditions permit, the ME is the magnifying endoscopy method can be used for the endoscopy screening for early upper GI cancer. Routine magnifying endoscopy is not applied in full magnifying mode throughout the examination, but rather switch to the magnification mode when the suspicious lesions are found, getting targeted biopsy. And in units with the conditions try to routinely apply magnifying endoscopy for screening. The process of screening and the diagnosis is combined. The links between the endoscopy and pathology are closely connected to determine the background of mucosa of gastric and determine the nature of the lesion. We suspect the lesion and is the benign or malignant. And magnifying endoscopy is a microscopic analysis after the overall operation of the routine endoscopy, determine the boundary, nature, degree of the differentiation, and the depth of invasion of guide decision to making the diagnosis. And for the consensus opinion 2, the magnifying endoscopy can increase the detection rate of superficial ESCC and the pharynx, and can increase the detection rate of the superficial Barry esophagus, esophageal adenocarcinoma, and also can to judging the background mucosa of the stomach and assessing the risk of gastric cancer. We have a lot of different classification of different upper GI cancer, such as the Japanese Esophageal Society Magnifying Endoscopy Classification, and the updated GES Barry Esophagus Classification, and the simplified magnifying endoscopy diagnosis method for the early gastric cancer, the demarcation line, and we will judge if the lesion is absent demarcation line, maybe it's a non-cancer, but it's present the demarcation line, we will to evaluate the microvessel or microstructure to evaluate if it is a cancer lesion, cancerous lesion. And the preparation for the work for the routine magnifying endoscopy, the screening of high-risk patients, we will recommend the routine magnifying endoscopy for the upper GI cancers. And it is recommended that the units with conditions that have a fixed operating room to do the routine magnifying endoscopy. And also we have a very the preoperative preparation of the patient selection, informed consent and inquiry and application from the writing. And for the preparation work for the endoscopy, we will assessment have the time before the gastroscopy, use the antipasmotic drugs and the observation, reaction, and the effects after the medication use before and during the examination. And also we will give the deforming agent for the patient, combine the medication and the drug dosage. We will to protect the original state of the mucosa. And for the pre-examination equipment and accessory, the nurse will equip with the black soft cap of our magnifying endoscopy. We will choose different the cap of the examination and the endoscopy. And for us, as a doctor, as an endoscopist, endoscopist, we will have the magnifying endoscopy parameter settings, the knowledge of the magnifying the settings, such as have the type A and type B, the A mode for the operation, relatively large structures, and the B mode for the observation, fine structures. So we will get the very beautiful image, just like this picture. And the basic observation sequence for the routine magnifying endoscopy, it is recommended to first complete the observation of the stomach and then observe the duodenum after the stomach observation. This is our recommendation from the hypopharynx and to the esophagus. And some key consideration, the comprehensive observation is not equal to the comprehensive image acquisition. The comprehensive observation is the top priority. The order of taken photos should follow certain principles, but it is not rigid. This is the standardized image acquisition for the hypopharynx. For the 1 to 2 image, and then is esophagus for the 6 to 8 images, and then is the different section of the gastric, from the gastric argo to the body and the atrium and the cardia. And then is the duodenum to have the standardized image acquisition. The duodenal bone and the descending part of the duodenum, including the papilla. And observation of the hypopharynx and esophagus is very important. In the case of a background of patchy esophagus, iodine staining is recommended. And also for the duodenum, it's very important to get the picture, including the papilla, to find some lesion of papilla, and judging the background mucosa by the combining white light and magnifying endoscopy. For the magnifying endoscopy observation and the biopsy process for the suspected lesion, we have some imaging for the distant view to median view and close view, just like from the forest and tree to leaves and go back to the forest. And the basic observation method and targeted biopsy from the distant to near, and from the normal to abnormal, and from the edge to center. The low magnifying for overall observation, and the medium magnifying for the observation boundaries and the microstructure, and high magnification for the observing microvascular and the typical changes. And this is the observation of multiple lesions under the background of the current Helicobacter pylori infection and after eradication. And this is a case of a patient for the 64 years old underwent the gastroscopy due to the anemia with a history of hypertension, diabetes, hyperthyroidism, and a family history of gastric cancer. We can see in the low part of the gastric body, a pale mucosa is visible on the posterior wall with pullular eradication in the center right, about 2 centimeters in size. And the lesion shows 0 to C type changes, magnified observing irregular MV and MS, and also have the demarcation line. And after indigo carmine staining and lactic acid staining, we have, if without the magnifying endoscopy, this lesion may be misinterpreted as a simple erosion or inflammation, potentially lead to the missed or incorrect diagnosis. But the pathological result is the signet ring cell carcinoma. So it's very important for the routine magnifying endoscopy and the targeted biopsy for process diagnosis. And we also have some quality control for the endoscopists and the department quality control. And this is the content of the report for the routine magnifying endoscopy of upper GI tract. And the next step is the standardized endoscopic treatment in the food chain. We have the multidisciplinary cooperation. For the physician and for the nurse, the physician-nurse team collaboration in endoscopy treatment have a high quality endoscopic resection requires. And also it's very important, the anesthesiologist and the endoscopist team collaboration. And this is some picture of the standardized endoscopic treatment and collaborations. And we also to know some electrosurgical knowledge and some the effect can be set and use the high frequency electrosurgical modes and also the safe use of the negative electrode plate and the placement of the negative electrode plate and the surgical anatomy knowledge. Also very important, and as a doctor of Department of Gastroenterology, pathological knowledge that endoscopy needs to master is important. And some different classification of upper GI cancer, and also very important the step is the perioperative management and include the preoperative procedure and the postoperative procedure. And also important is the processing of our ESD pathological specimens in the pathology department, and the histotechnist process it through the following steps: the gross examination and standardized sectioning and enhanced visualization and preliminary assessment of lateral, and some key technical specification. And this some picture of the step of in the pathology department to have the specimen growth. And the photography after resection. And the photography after resection, we have the very correct pathological results of the lesion. And we need the endoscopy pathology integrated diagnosis. It's a standardized pathological diagnosis of early GI cancer requires close collaboration between the endoscopy and pathology. And this some work we do for the integrated endoscopy pathological diagnosis. And we will get a very standard pathological report, include the cross-tab histological classification and depth of the tumor invasion and the presence or absence of vascular invasion and the mode of invasion and the horizontal and the vertical margin and other lesion and pathological staging and the drawing of the mucosal lesion linkage and diagram. This is a very standardized and detailed pathology report of one person. And the last step is the follow-up, link post-treatment follow-up with the lesion screening tool from a closed loop. And this is the panoramic view of the food chain from the screening to diagnosis, from the diagnosis to treatment, from the perioperative management to post-operative follow-up, and from the endoscopy to pathology, and from the medical care to nursing, from the clinical to medical technology, promote a comprehensive understanding of GI endoscopy, early GI cancer diagnosis and treatment, as well as related disciplines, strengthen collaboration between the endoscopy, pathology, and the nursing, and enhance the connection between the endoscopy, anesthesia, and the surgery. Thank you.
Thank you very much, Professor Chen, for this comprehensive presentation of full chain of diagnostic and treatment of GI cancers in China. Unfortunately, we have not time for many questions, but probably one or two. just a few minutes ago, we finished the symposium on artificial intelligence in endoscopy. In your unit, do you use artificial intelligence to find and to characterize the gastric cancer, for example?
Yeah, in our hospital, if the patient got the HPV infection or have the HPV eradication and got the chronic trophic gastritis, maybe it has a high risk get the gastric cancer. So for this person, for this kind of patient, we will give the routine magnifying endoscopy for them. And we have a fixed room for him. I remembered I have a 60-year-old the man. He didn't have any family history of gastric cancer, but he got the HPV infection from 20 years old. But he didn't do any eradication of the HP. But in 60 years old, I do the routine GI, upper GI endoscopy for him. I remember I used the magnifying endoscopy, and I found a very small lesion in the ultron. And because I use the routine magnifying endoscopy, so I do the magnifying for this lesion, and I found the demarcation line and very irregular the MV and MS for this lesion. After biopsy of the lesion, it is a high-grade dysplasia, and then we do the ESD for this patient.
And one more question. In patients where you have atrophy, intestinal metaplasia, but Helicobacter pylori negative, do you use, for treat these patients, some special kinds of Chinese herbs or Chinese drugs, which is not available in Western countries?
Sorry.
In patients with atrophic and intestinal metaplasia in the stomach, HP negative.
In our country, because the herb, the medication, some clinical research have some the clinical result it can have a very good effective for the chronic atrophic gastritis, for the metaplasia and the dysplasia.
Okay.
So we will give some the herb for the patients,
Okay.
for the medication.
Thank you very much,
Thank you.
Professor Chen, and once more applause
Thank
for
you.
you. And it's a pleasure to present the lecture of Professor Peng, our good friend and I would say now old friend. Please, Professor Li.
Yeah. Yes, thank you, Professor Evanov. Thanks for the invitation. So, yeah, thank you. It's a great pleasure to come here and learn a lot, especially from the morning, the afternoon. And also, I think our visit of our group to Russia will consolidate the brotherhood relationship between the Chinese Society of Gastrointestinal Endoscopy and the Russian counterpart. Thanks again. Today, my topic is therapeutic EUS for biliary and pancreatic diseases. So this is my hospital. So it's launched by the Chinese and the former Soviet Union government. At that time, they reached an agreement to establish a big hospital in Beijing through the assistance of the former Soviet Red Cross in 1942. And this picture is in 1954. And at that time, the name of the hospital is China Soviet Union Friendship Hospital. And in 1974, the name had changed to Beijing Friendship Hospital. So for the US, it's originally is considered the kind of imaging, and then we could give the qualitative diagnosis through the US FNA or FNB. Now we consider the US a kind of interventional therapy, just like the biliary drainage, the anastomosis, radiofrequency as therapy, and the fine needle injection therapy, etc. So for biliary disease, what we often use is ERCP, but sometimes ERCP has a kind of failure rate, just like cannulation failure or surgical altered anatomy or inaccessible papilla. So at that time, we could use EUSBD as a kind of alternative. So the success rate is more than 75%, and the complication rate is 10%. So here's an example. So it's an old man, the Whipple post-operation obstructive jaundice due to pancreatic cancer recurrence. Duodenal papilla was not reached endoscopically, and the MRI shows obvious dilatation of the intrahepatic and extrahepatic bile duct. So now we use US hepatogastrostomy to treat these patients. A 19-gauge needle was used to puncture the intrahepatic duct in the left lobe of the liver. Then the gateway was delivered, and the dilatation of the root by the bougie dilatation, as well as Sohander retriever. And at the end, a plastic stent was implanted for bowel drainage. After the procedure, the bilirubin level has decreased dramatically, and the patient's symptom get decreased. So the right side is show the picture, a plastic stent between the intrahepatic duct of the left lobe of the liver and the gastric lumen. And 6 months after the procedure, the patients have recurrent obstructive jaundice. Now we use a pigtail stent to just come across the gastric lumen to the biliary system to the small bowel, a very long plastic stent. How to broadcast it? Yeah. So it's obstructed plastic stent. We just how to just quick. I couldn't control, the video. So I want it got much quicker. Yeah, it's dilated, the common bile duct. Quicker, much quicker. Impossible. A lot. Just there's a lot of time. Sorry for that. So this time we use rannavo technique. The gateway inside the common bile duct come across the papilla to the small bowel, and is a failed ERCP procedure. With this technique, we could, successfully cannulated the papilla, then put a plaster stent for these patients. 不行是吧？不行，我就下一页了哈。Sorry for that. There's another patient, she's a 77 years old female. It's a past medical history of the total gastrectomy and a root-wide reconstruction for gastric cancer. So CT scan shows this choledocholecysis and cholecystolysis. But the patients, the ERCP couldn't get the papilla area because of the pastel, surgery. So this time we use the US, antegrade, a stone removal technique under the US surveillance. So it's a small bowel. 还是快不了是吗？Sorry for that. So I just tell you the procedure. So the US, is a puncture of the, the left side of the intrahepatic duct, then get very inside, come across the papilla to the small bowel, and dilatate, the root with, the balloon and the dilatation of the papilla area. Then use the balloon to push the stone to inside the small bowel. So just remove the stone, use antegrade, use a technique. So what's next is gastric gallbladder metal stent implementation. For this patient, he's 75 years old. His chief complaint is obstructive jaundice for more than 2 months. So the first procedure is the ERCP because the patients have the past medical history of the gastrectomy. So we just go to in the afferent loop, but the papilla couldn't access because of the tumor intrusion. So next is the USBD, and successfully access into the intrahepatic duct and get very inside the intrahepatic duct. But the cooperation between the operator and the nurse, is the failed, USBD technique. So because the gateway is lost its position. So what's next? So the gallbladder drainage. So we have the very enlarged gallbladder and punctuate, so a fully covered metal stent into the gallbladder, and the patient's symptoms get relieved. Here's a case of the US GBD complication. So the patient is a male, obstructive jaundice, and ERCP failed, PTCT failed because of the intrahepatic duct is not so dilated. So for this case, we have the US gallbladder drainage. Yeah, so with a 19-gauge needle, puncture of the gallbladder. But this is the first time for me to use the axles for this kind of situation. So you could observe, the stent come across the gallbladder, the perforation happens. 还是快不了。So this kind of adverse events, how to deal with it? As operation, we just place the axles, the stent in the lumen of the gallbladder. Then change, for direct view endoscope inside the gallbladder with a metal clip to just, fix, the perforation. And also USGE could be useful for, some biliary disease or the pancreatic disease, just like pancreatic cancer. Often we use a duodenal stent, but there lack patency for the stent each 2 to 3 months. We use USGE just to deal with the patient's problem after the vomiting as very long lack patency for the stent. In one case, we could find a dilatation of the and fluid accumulation of the duodenum, and the patient has a pathological history of the biliary stool gastrectomy, and which means the afferent loop obstruction for these patients. So we have the direct view endoscope into the gastric lumen, found another problem. This is a gastrocolic fistula. So first, to deal with the problem of the fistula. We use OTSC over the scope, the metal stent, metal clip, to close the fistula is the first step. The second step is the knotting gauge needle to puncture the afferent loop and put an axial stent between the gastric lumen and the afferent loop. So one procedure deal with the two problems. Just before, it says close the fistula, we use APC to deal with the mucosa. Then with the help of the OTSC to close the fistula. The next step is just axial stent. Time counts. So after several months, we can follow up the patients. It's very well. The second case, I believe this cases, and also USPD for patients of chronic pancreatitis. So a field ERCP. And a US observation, we could find dilated or the pancreatic duct, and also a plus stent, for the pancreatic duct. So next step is use as lithotripsy to just get rid of the pancreatic stone. Also, for the patients of the pancreatic cancer or chronic pancreatitis, pain is a problem. We often use USCPN to deal with pain of the patients. For these patients, is pancreatic cancer. In the head of the pancreas, we find a mass. First, we use FNA of the head of the pancreas, as well as liver metastasis, as well as enlarged lymph nodes to get the diagnosis of the pancreatic cancer. Then USCPN to relieve the pain of the patients. This is the last case. It's a male, is 83 years old. So it's hypoglycemia for 15 years. Have the CT scan shows this insulinoma in the tail of the pancreas. But US in another hospital, also in my hospital, couldn't find the lesion. But CT shows it's a tumor in the tail of the pancreas. So we changed, the route of the US examination from the oral side to the anal side. From the anal side, we could find the lesion in the tail of the pancreas and have the fine needle injection of the alcohol, 1 milliliter of the alcohol, to just relieve the symptom of the patients. And also C-peptide and insulin level decrease a lot. Thank you for your kind attention.
Thank you very much, Professor Lee. We have a question from our colleague, please.
Microphone, please.
Thank you for your wonderful message, Professor Li Peng. I'm from Moscow, from Vishnevsky Institute of Surgery, and my question is about biliary drainage under health control. This is a rather complex procedure, and do you think this procedure should be used more often in routine clinic practice?
Yeah, I totally agree. It's a very difficult and complex procedure. So should only used in a high-level hospital and also very experienced endoscopist. The endoscopist should acquire, the technique of the advanced ERCP is the first requirement. And the next is under very treating, very severe, treating for, endoscopist. Also some kind of adverse events, happens for me and for my colleagues. What we do, we just use animal, for alternative for treating. But just like the gallbladder drainage, we have just finished more than 10 pig for the gallbladder drainage, then perform this kind of technique in clinic. Yes, thank you for your question.
Thank you very much. And I want to say that in our Vishnevsky Institute of Surgery in Moscow, we have already held 2 national health congresses. And we are very pleased to invite you to participate in our 3rd Congress at 2026. Thank you.
Yeah, thank you. Thank you for your invitation.
Well, if we haven't more questions, thank you very much, Professor Lee, and wish all the best for your difficult work. Михаил Павлович, вам предоставим право закрывать симпозиум, или нам оставляете? Ну что же, мы попробовали, во-первых, новый формат, без перевода. Пора, все учили английский язык, тем более, когда говорит не англичанин, была надежда, что, может быть, вот когда мы проводим Китайско-Российские эндоскопические форумы, кстати, ближайший будет от Евгения Геннадьевича, да, из Алмазовского центра, осенью ближайший будет. Там мы разговариваем и делаем презентации на русском языке, а искусственный интеллект на Китай переводит подстрочником на английский язык, соответственно. Может быть, и на китайский тоже, не знаю. На российско-японский. В общем, потихонечку осваиваем. Давайте, я думаю, что мы еще раз поблагодарим наших гостей из столицы Китайской Народной Республики, поблагодарим их за очень интересные лекции, пожелаем им всего будущего и, надеюсь, увидимся вскоре вновь.